Hi everyone, it's me, Sandy Cruz of Sandy K Nutrition, Health and Lifestyle Queen. For years now, I've been bringing to you conversations about wellness from incredible guests from all over the world. Discover a fresh take on healthy living for midlife and beyond, one that embraces balance and reason, without letting only science dictate every aspect of our wellness. Join me and my guests as we explore ways that we can age gracefully with in-depth conversations about the thyroid, about hormones, and other alternative wellness options for you and your family. True wellness nurtures a healthy body, mind, spirit, and soul. And we cover all of these essential aspects to help you live a balanced, joyful life. Be sure to follow my show, rate it, review it, and share it. Always remember, my friends, balanced living works. Hi everyone, welcome to Sandy K Nutrition, Health and Lifestyle Queen. Today with me, I have a special guest and she is so awesome. Her name is Dr. Anna Cabeca. Many of you know her as the Girlfriend Doctor. She's the best-selling author of the Hormone Fix, Keto Green 16, MenuPause. Anyway, today is going to be an amazing conversation where Dr. Anna and myself are going to talk about everything you ever wanted to know about menopause, but were afraid to ask. Dr. Anna does have a bunch of amazing quality products. I have been using a couple of them, and I will have a link in the show notes for a discount so that you can try them yourself. So, I don't know if you guys noticed, but I changed my intro to my podcast. I'm actually really excited about this. I've written a few articles as of late on why I really don't want to be associated with the term biohacking any longer. I really just don't resonate. And I wrote a really good article. I'm really proud of this article in my Substack, and it's called Why I No Longer Use the Word Expert. And I've gotten some great feedback on this article, and really it's secrets of this entire wellness industry revealed. And I go through a discussion on, if we can't trust the wellness experts, who can we trust? And you can read this article if you join my Substack. It's sandycruz.substack.com, SandyCruz.substack.com. And I really wanted to change just that entire intro because it sort of made me cringe a little bit. And I've been finding that term and the industry, this entire wellness industry, has been making me cringe in a lot of ways. I'm not saying there are not people who are honest, authentic, with integrity. That's not what I'm saying. But what's happened is the money, the power, the ego, the greed, all of that is overshadowing all of these people who are just trying to do good in this industry. People who are that hero's journey and who do want to help others just live a healthier, happier life. So please, I'm going to ask you to do your part because I do send out free content all over the place, all the time. Please share this episode with someone who you feel might resonate. Number one, please review it. So all you got to do, if you use Apple, go to my podcast, just search Sandy K and you'll see Sandy K Nutrition come up right away. and click on that and scroll down to write a review. Give me a 5-star review. Provide me with a little bit of, love and a few kind words. That goes such a long way. So share, rate, review. And I think Spotify also allows you to do the same. I will be part of the Reverse Aging Summit. This will be online. I'm really excited about this. There's more to come. It will be free. It'll be over 21 days. It's launching on March 31st. I'll be one of the speakers there. So look out for it. Link will be coming soon. Follow me on all of my social media platforms. Anywhere you do social media, just look for Sandy K Nutrition and you'll find it there. When you join my Substack, by the way, I am going to be starting a new podcast. It will be a short form podcast called Think About It, between 6 and 16 minutes each week. Just a new topic in wellness for you to think about, because that's not your jam. That's not what you do. But what I do is I think about a lot of things in this wellness industry, and I do a lot of research. I know a lot of people. So that's why I started this podcast. It's just for you to think about things in a different way that could benefit you. One last announcement. If you are a business, so you're a business, you are established, and you currently work B2C, and you want to move to B2B and actually have distribution access to some of the big box stores in Canada. I'm Canadian, even though most of you are American. Please get in touch with me. And I say big box, I'm talking about Costco, I'm talking about Walmart, I'm talking about Canadian Tire, all of these big box stores. Please get in touch with me and email me, and we can have a chat. It's sandy@sandyknutrition.ca. Get in touch. Now, let's cut on through to this amazing interview with Dr. Anna Cabeca. Don't forget to share. Hi, everyone. Welcome to Sandy K Nutrition, Health and Lifestyle Queen. Today, my guest is Dr. Anna Cabeca. She is a DO, OBGYN, FACOG. You've got many of these beautiful acronyms behind your name that show all the hard work that you have done in this industry. And Dr. Anna is known as the girlfriend doctor. She's the best-selling author of the Hormone Fix, Keto Green 16, and MenuPause. Dr. Anna also has her own podcast called The Girlfriend Doctor, a health podcast to help women live better lives through all stages before, during, and after menopause. Dr. Anna truly has longevity in the space of women's health and has served over 10,000 women in her private practice. She has created resources to help millions through her books, online videos, and articles, and has even created numerous products to help support women's health. And today we're going to talk about menopause, of course, and we're going to discuss everything you ever wanted to know about menopause, but you might have been afraid to ask. And I know that we're going to have some nuggets in here that are not really commonly discussed during menopause. And I'm sure you wouldn't have had these discussions with your general physicians. So you're going to hear it here from Dr. Anna Cabeca, who is an expert in this area. And with that, welcome. Thank you so much for coming today.
Oh, it's great to be here with you. Thank you, Sandy.
So I have to ask your background. I always ask my guests, how did you get to where you are now? Because you've been doing this for a long time.
Yeah, no, I have. I originally, I've always wanted to be a physician. So my mom is a Palestinian Christian Arab and was an immigrant to the U.S. after marrying my father, who was U.S. Navy. And so with my mom's culture, food was always medicine. But the relatives, three of her, two of her brothers and herself, so 3 out of 11 that came to the U.S. all died from illness, cancer, diabetes, heart disease, before their other siblings living in war-torn Palestine and Lebanon. And I was very young to realize like something is wrong. We had all these interventions, all these medicines. And when my mom passed away, she was only 67 years old. And that was undergoing a second heart surgery. The first one she experienced at age 52 years old, cardiac bypass surgery. I was 16 when she had that done. And I realized the surgery that they were performing on her had only been done on research on men. So never, not on a postmenopausal female or a perimenopausal female. And that kind of opened my eyes. That opened my eyes, and I dug into the research, and I became a researcher before I went to medical school. So I always try and understand why and the mechanism of action, how the body functions. And then, the concept of food as medicine, traditional medicine and lifestyle, how that impacts our health. And this is something I tell patients come to see me from around the world, right? And so I see patients from around the world, and I will always tell them, I said, we're going to test, and I'll test every one of your body fluids. We're going to talk about all kinds of things. But the most important thing that's going to improve the things that are going to improve your longevity and quality of life the most are the free things. And it
Mm.
is so true. It is so true. Quality food, quality relationships, positive, mindset. I call it oxytocin increasing behavior. So as I studied women's health. I've continued to study functional medicine. I'm triple board certified in including in integrative medicine. And I think there's an East meets West philosophy into holistic and longevity care. It's not just about how many years we live, it's the quality of those years. I'm really passionate about this because I see, you know, people from really privileged circumstances very, very sick because of modern healthcare.
Oh, wow. We are definitely aligned in a lot of that because you do see that often where individuals are unwell, whatever the circumstances are, and they look outward and they don't look at what's right in front of them. Like, what are you putting into your body? Are you moving every day? And you don't have to have an expensive personal trainer to move every day. And so I
Well,
am,
hold on. I kind of need a little extra support there. I'm kidding.
well,
I could
hey,
use someone shoving me out of bed. I get up in the morning. I do my boxing workouts at 7, but I have a trainer come twice a week. But I do other stuff other days.
you,
But
okay,
it does make a difference. You do not have to, however.
you
It
don't
is
have
for
to.
sure.
Yes. So it's interesting because I had a personal trainer for many years, for 6 years before I hit the menopausal years. I think I was 47 or 48 because I'm like, I got to build some muscle. And then I kind of learned a lot. And then I realized, okay, it was becoming harder for me to have a personal trainer. So I don't need it. So I think what you're saying, everybody kind of has their own thing that works for them, but really, you don't have to do that.
No,
You don't have.
nope, no.
So, and
It
often,
is free to move. It is free to move. Yeah,
yeah, yeah.
absolutely.
So, menopause is obviously you hear many definitions of menopause. Like, am I in it yet? Am I not in it yet? Like, when am I in it? Is it done yet? So, let's kind of define what menopause actually is. There's the time before, the time. So, let's talk
Yeah.
about that.
The terminology is so terrible, Sandy. So, according to our medical textbooks, menopause is the day 12 months after your last period. So you have a period once every 6 months. For 2 years, you're still perimenopause. And I've had clients who didn't have a period for over 12 months, even one for 2 years, and then their periods start again. Okay, was I menopause? Am I not menopause? What's going on? It
Yeah.
is it's so, again, terrible terminology. It's really better to use the term perimenopause for this time period. And then the day after 12 days of no period, that day being menopause, the day after that is considered postmenopause.
Mm.
So and the perimenopause is that, you know, symptomatic time, 10 up to 10 to 15 years before your last period. And where it gets really confusing is if you've had a hysterectomy with your ovaries removed or with them maintained. And this is like, women are always like, well, am I in menopause? Am I not in menopause? What am I supposed to do at this point? When do I, when can I benefit from hormones or not? And do I no longer need progesterone because I don't have a uterus? I mean, there's again so much misinformation and confusion out there. So if you're listening to this, you hear Sandy and me talking, and I get being confused. I was an OBGYN resident, and again, my own story, I was diagnosed with early menopause at 39. I went on to reverse that. That's not something we're told we're able to do. And so, that is it. So the terminology is confusing. Premenopause is also that time before menopause. So you have premenopause, and that can be from reproductive years until you become symptomatic. And then you jump from premenopause to perimenopause. And then you have your 12 months without a period. Now you're menopause. And then next day, you're postmenopause.
Like one day.
One day.
One day. Yeah, because so then technically, I guess I'm going to be 55 in January, but because I had a mini period in March, technically I'm still in perimenopause if you were to
Yep.
look at the definition. So here's the interesting thing, and I'd love for you to expand on this. The thought process in the majority of, general physician, Western medicine is that you do not start estrogen until you are in that 1 day post menopause, like 1 year,
Yeah.
no period. So I've actually personally heard this myself. So a woman can suffer for a long time before she's in that magical, okay, now you have the green light and you can take hormones. What are your thoughts
Yeah.
on this?
I have studied this area extensively. I've studied it, and the precursor hormones and the hormones that change over time. And first and foremost, it takes more than hormones to fix our hormones. Nutrition, lifestyle, good sleep, positive mindset, decreasing stress, becoming insulin sensitive, all of those things impact your hormones way more than when we start supplementing. And detoxification, that's key. I mean, traditional medicine, I've studied medicine around the world, from Ayurvedic medicine to traditional Chinese medicine. It looks at the liver and the kidneys. You want to detox liver and kidneys to support your hormones. And that is so true. That is so important. So first thing, when you become symptomatic or before you're symptomatic, detox needs to be part of our daily lifestyle because we are inundated with hormone disruptors, toxins, nutrient deficient foods. If you eat out once and you get like chicken or steak, they've been given antibiotics, and now you've gotten a dose of antibiotics, even though you don't, you would say, oh, I won't take any antibiotics. So you've already got them just from eating out. So that affects your gut bacteria. So we have to replenish and restore all of this stuff on a daily basis. It becomes part of a healthy practice. And then as our hormones decline, DHEA, which is the precursor to testosterone and estrogen, starts to decline for both men and women in our mid 20s to 30s. So this is where in that time frame, like I will add adaptogens. For me, it's the combination of adaptogens in my formula, Mighty Maca Plus. And so it's a combination of 30 superfoods that work together to help with detoxification, help with alkalinization, help feed the gut microbiome, help with liver support, and adrenal support. So now you're producing more of your own DHEA naturally, and your body's using your hormones better. And then if we're like, okay, we need additional support beyond this, of course, extra vitamin C, B vitamins, additional adaptogens we can use, and then we can supplement with DHEA. So I typically do it topically because, every form of oral DHEA I've tried gives me acne and breaks out. And at 58 years old, I'm not doing it. But even early on, so I use topical DHEA, and that's in my Julva cream. And then the second hormone to decline, Sandy, is progesterone and pregnenolone. So really progesterone from age 35 to 55, we lose 75% of our progesterone compared to 35% of estrogen during that same time period. So that's a powerful shift. So then we'll supplement with progesterone and pregnenolone, definitely progesterone at least. with or without a uterus during that time play, because the symptoms of estrogen dominance are symptoms of estrogen insufficiency typically and impaired estrogen detoxification. So you want to support those hormones during that time, and then testosterone and estrogen.
Hmm. That actually, the order in which you explained it makes sense. But DHEA is a hormone that is not talked about as much.
No, I
So,
know.
and I took certifications in endocrinology and hormones. I am a registered holistic nutritionist. I'm not a doctor, but I understand hormones and I understand the cascade of hormones. So maybe we always learned that DHEA was like the mother hormone, like it's kind of at the top of. And could you just explain the way that it works within the body? I think it would really
Yeah.
benefit a lot of women to hear this.
Yeah, no, it's so powerful too. I mean, when we think of like how our hormones are derived, first of all, DHEA is a powerful adrenal hormone. In our reproductive years, we make 50% of it in our ovaries, and the other 50%, it's estimated, in our adrenal glands. And so as our ovaries start to decline in function, we start to make less DHEA from there. We think of the hormonal cascade and how our hormones are derived. Our hormones are derived from cholesterol. Cholesterol is not a bad guy. It is protective. It is necessary. I mean, all our hormones are derived from cholesterol. We need healthy fats in our diet. So from cholesterol, we make the mother hormones progesterone and pregnenolone. So progesterone and pregnenolone, progest, so that means pro-life. Progesterone is a pro-life hormone. It helps maintain, without healthy levels of progesterone, you cannot maintain a healthy pregnancy. So it is technically pro for just for life birth hormone. So progesterone and pregnenolone. Pregnenolone is not talked about, and it's such a powerful hormone, and the combination of which, I mean, pregnenolone helps with mood memory. And so from cholesterol, we make progesterone and pregnenolone, and then we'll go on to make DHEA. And then from there, we're making testosterone and estrogen. So it's kind of that cascade when we think about it. So if we work on filling the tank from the top down, we're going to want to support progesterone, DHEA, testosterone, and estrogen, and carefully so. Again, because it's a nuance, there's a symphony when it comes to our hormones, and we don't want to suppress what our body naturally produces. But for sure, I think, and progesterone, it's like estrogen. These have gotten such a bad rap. Seriously, the conversation around women's hormones has been misogynistic for the last 2 decades. It really has been. And so estrogen said, oh, we need to be anti-estrogen and create incredible havoc and disservice to women. And then progesterone combined in with progestins, just so we don't disrupt the marketing of big pharma's synthetic progestins that they were able to patent because they couldn't patent bioidentical progesterone. And progestins cause breast cancer. Bioidentical progesterone does not. And then further, I'm going to say misogynistic conversation was that if you don't have a uterus, well, you don't need progesterone. Progesterone is one of the most neuroprotective hormones in our body. It is critical for memory, mood, and good night's sleep. So why wouldn't, if we don't have a uterus, we don't need that? So it's really been a problem. I've been on the forefront really now for 2 decades, trying to educate other physicians on hormones and hormone prescribing and the safety and efficacy, and again, there's right and wrong ways to do it. So yeah,
Hmm.
it's a hot topic, Sandy.
Yeah, you don't want to overdo it either. I know I know that both progesterone and estrogen can give you some symptoms that are not great if you overdo it. And I know I've been in the situation with progesterone, and it can give similar symptoms to too much estrogen, like the bloating and even some spotting and then feeling
Weight
like that.
gain. Yeah.
Yes. Yes.
And
So
that's if you're pushing the cortisol pathway. So I would ask you, when you were taking that progesterone, was it a high stress time for you? Were you possibly pushing those cortisone pathways?
100%. I was
Yeah.
trying to recover from COVID.
Yeah.
So my
Yeah.
body was already under stress. And
Mhm.
it was after a pretty major vacation. I ended up getting COVID. And then I was having some trouble sleeping. And my practitioner said, well, you can try going up a little bit in the progesterone, but there was, my body was not having it, Anna.
Yep. Yep. That's because progesterone is a precursor to cortisol. So then we're going to be pushing, like sometimes if you've got the pedal on the gas and you add more gas,
Yeah.
you're going to run that pathway. And that's when you get those symptoms. Like you can get hair loss, weight gain, acne, breast tenderness, just feel inflamed, all of those things from pushing that pathway. So then we have to back up, right? We have to
Yes.
back up, support the adrenal glands, back up, reset the circadian rhythm. And sometimes, we can bypass that cortisol gas pedal by using topical pregnenolone with progesterone just at small micro doses till we need, during that time to help with sleep, relaxation, mood, memory, but not to push that cortisol pathway.
Yeah, I love that you said that. And then the other thing that I think a lot of women don't understand around menopause, it's not talked about enough, is how important supporting adrenal function is because your ovaries are going to say goodbye soon. So it's almost like we want to do that preemptively. We want to be proactive about supporting our adrenal glands so that they're like in good shape. It's like, you know, getting prepared for a marathon, right?
Absolutely. Absolutely. And I'm smiling as you say that because when you said, okay, we got to talk about supporting our adrenals, that is key. I was doing a live for Menopause, World Menopause Day that we had October 18th, and I had a series of lives going on. And someone showed up during the lives and says, well, how can it was a husband of a woman going through menopause, and he was so sincere. He's like, how can I help my wife during this time? How can I be supportive of her? So when you said that support, it triggered me back to that conversation because that's such an important piece. Like we have to definitely as women put our own oxygen mask on, but our support network makes an incredible difference. And being able to ask for what you need help support around and create those healthy boundaries. And I think a lot of times we're powering through our hormonal symptoms. We're powering through our activities as if nothing's changed. And when we really need to step back and say, okay, if it's not a hell yes, it's a hell no. And
Mhm.
let's create boundaries around this and let's prioritize this time for self-care. Let's get the extra help and support I need. And that's a powerful choice to make. And the adrenal glands are probably because I had PTSD and complete adrenal fatigue in my 30s and struggled with PTSD in through my 40s, post-traumatic stress disorder, then convert that to post-traumatic growth, right? We want to have post-traumatic growth where I have traumas. How do we convert that to post-traumatic growth? But healing the adrenal glands was key to doing that, to go from post-traumatic stress to post-traumatic growth.
Yeah, I can relate to that. I just because I think it took almost 2 years for me to bounce back after. So my daughter, she was diagnosed with cancer and I had thyroid cancer 1 year after her. And then, my husband coded in the hospital. This was like I
Oh my
call it a
gosh.
snowball effect. And then doctors would say, well, adrenal fatigue doesn't make sense. It's not a thing. But then when I actually started seeing a naturopathic doctor and doing proper testing, I saw, I saw that my cortisol was almost flatlined. So it's seeing the right practitioner for the right thing, and everybody has their strengths and everybody has their weaknesses. You want to see the right practitioner to help you. But that whole adrenal piece for me was so huge. And I didn't even realize how important it was, but it took time.
Yeah, it's a constant. I mean, it really is a constant. So the adrenal glands are, it's like the adrenal glands, like the ovaries, they're both fragile and they're both really tough. And so it's part of this communication network, a hypothalamic, pituitary, adrenal, gonadal axis, right? This communication system. We can't separate the head from the rest of the body. It's all connected. And when it comes to adrenals, the terminology has been challenged, so adrenal hypofunction or adrenal dysfunction, that's key because the adrenals are being suppressed. It's not that they're worn out per
Yeah.
se. So that's where that terminology got confusing. And plus, endocrinologists still don't understand the adrenal gland. So we'll just give them grace on that one. But adrenal hypofunction, adrenal dysfunction. And I think that's important to look at again the different stages of of disorder that's associated with adrenal dysfunction.
Yeah, I think we're much more complex than we even realize. But I
I'm
have to
always
go.
learning.
I know, right? And we can't really simplify it. So we have to do our best in all the different areas of wellness to support our bio individuality, because that's the other thing is that we're not a one size fits all. And for me, especially right now, hormones are still kind of going up and down. And I still see changes. And I think that you probably see that a lot in your practice with late stage perimenopausal women,
Mhm.
where, there is no real perfect dose for a while of
Yeah.
hormones if they go on the hormone therapy.
Right. And that's where it really becomes nuanced, where you can, really learning your signs and symptoms of your body, and I teach this to clients. I teach, an 8-week program called Magic Menopause. And the key thing is understanding, okay, well, these are symptoms of estrogen dominance or estrogen deficiency or progesterone dominance or testosterone insufficiency. I mean, just name it. And so like it's important to understand because especially when you're on hormones, you don't want to the birth control pill will suppress your body's natural hormone production. It's been the first line of therapy that as OBGYNs we were taught to implement for our patients going through PMS or mood swings or, um, premenstrual and depression. And so these are, I mean, those were like, I just shut down their ovaries and we'll go from there. And that the symptoms that our body telling us are like signpost. It's an indicator there's something going on, something that needs to be addressed. But to shut down that process is doing your whole body a disservice. And so when and we don't want high doses of hormone replacement therapy either because it's doing the same thing like a birth control pill. So we want to be able to work with our ovaries, with our adrenal glands. And there's sometimes we need more, sometimes we need less. It's hard in perimenopause. When you had a period, maybe a spotting or a breakthrough bleeding, it's so irregular. So when I have that with clients, it really just is going to depend, but I'll typically say, let's just do continuous, again, always adaptogen. I have them follow my Keto Green nutrition lifestyle plan to become insulin sensitive, to detox, to address cortisol, all that stuff. That's all part of the plan, but I'll add the adaptogens and then I'll add progesterone. I may use it continuously for 2 months to see how their cycle is. If it comes in, if they have a cycle while they're on it, I'd still for that first 2 months. Again, if it's been 6 months or something since they've had a period, but if they cycle when they're on that continuous 2 months of the progesterone, to stop it for 10 days and then start again. And that just does help. It does help balance the symptoms. It does help with the, breakthrough bleeding and irregular cycle. It does help with getting a good night's sleep. And so there's different ways that we can navigate the perimenopause, but it's always about becoming more insulin sensitive, alkalinization, detoxification. That is key to, completely getting rid of the symptoms of perimenopause.
So what are your thoughts on sulforaphane as a protective component when you are on bioidentical hormones?
So, when we talk about, like, for example, SGS, sulfuric, excuse me, excuse me, I'm sorry. Hold on one
No
second. Just got
problem.
some water.
Normally that's me. because I'm the one who's recovering from COVID. I'm like,
Yeah.
I'm constantly clearing my throat normally. And anyway, so far so good.
Yes. No, you're doing great. Okay. So where were we? So regarding sulforaphane, and specifically like sulforaphane glucosinate sulfate, which is a SGS for short, and it is a really powerful detox phase 2 detoxifier, liver support, and helps with estrogen detoxification. There's definitely different ways, but it's one of my favorites. DIM is also another one that works for most of us. It does depend on some epigenetics, and looking at urinary hormone metabolites and pathways can give us an indication of what's going on there too. So,
Yeah,
yeah,
you're a fan of the Dutch test, aren't you? Are
I
you?
am. I
Yeah.
am. Again, I like the Dutch test. I've been using that one. What you get familiar with, you use more. I've also used the HUMAP and Meridian Valleys test, and uh,
Yeah,
yeah.
I've been doing the Dutch test since my 40s, and really for me it was a I found it to be so eye-opening on the whole, exactly what you're saying, the detox pathways. How am I detoxifying estrogen? In my 40s, I was typically very estrogen dominant. And then now that I'm almost 55, it's like, you know, it's dropped down considerably. It's barely there. But it is time for me to do another Dutch test because I think it's still important to see, where are the estrogens going,
Oh,
right?
that's one of the most important things to look at.
Yeah.
Absolutely.
Yeah. So I wanted to go back to the whole cholesterol discussion because maybe you can provide a little bit of insight in this. Almost every woman, almost that I speak with, that's around late stages of perimenopause or in menopause or postmenopause have issues with cholesterol. And different I've heard different theories, different responses. I would love to hear your response on why that might be.
Yeah, no, it's really interesting and fascinating. So I always say if cholesterol's high, ask why. That's first and foremost. If it's high, is it because your thyroid's hypofunctioning? So it's an underactive thyroid gland. You're not producing enough thyroid hormone. Cholesterol will go up. Just correcting the thyroid will normalize it if that's the reason. The other reason cholesterol could be high because is it what happened in your life? Was it a high stress time? Did you have dental procedures, amalgams, like metal filling removed, exposure to heavy metals somewhere? Cholesterol will go up as a neuroprotective to protect your brain essentially from heavy metals. So, is it up because of that? Is there genetic? What's the genetic component that you're dealing with when it comes to elevated cholesterol? And it's probably more important to look at apolipoprotein B and LP little a and evaluate and the LPIR. That's even more important to me than total cholesterol and good cholesterol, bad cholesterol, and particle size of the cholesterol. All of that's important to look at in context. And triglycerides, you want to look and get those numbers optimal. But first, you really want to focus on, well, what is it doing? Is it damaging? Is this part of the damaging? Is this causing soft plaque? More common in women versus hard plaque. Is it causing any plaque in my body? And those are the questions we need to be asking in menopause and perimenopause. Cholesterol itself is not a bad guy, but we want to optimize it. And so, healthy, again, choosing healthy fats and choosing lifestyle modifications and regularly supporting, detox, liver detox. Is there mold chemical detox, all that, heavy metal detox. I mean, address the issues that could be causing it to be high and then go from there. Yeah.
Hmm. Yeah, I find it very interesting how it can change too, because I personally had a big bump in cholesterol after travel, and then during COVID. Neat, huh? Thought it was kind of interesting. I always like to look at anomalies in
But
my
it's good you're
belly.
asking those questions, right? Okay, what
Yeah.
was I doing?
Yeah.
What's been happening in my life around this time? What's going on? And that's exactly I tell my clients that we have to Nancy Drew. We have to put our Nancy Drew hat on and really look at all the clues. What's going on? And it's kind of cool to figure that out and say, okay, well, with COVID, we know whether infection or injection, but that it's causing abnormals and lipolysis. It's causing abnormal lipogenesis, abnormalities and blood clotting. And so really paying attention to that and looking at those markers has become part of my practice, where pre-COVID, it was never, was not high on the priority list, but now it's part of everyone's post-COVID care.
Yeah. Yeah. I agree. I think we have to all kind of learn how certain things will affect us, especially now, post COVID. I mean, we got to look at it. So I would love to get into the whole discussion on uterine cancer, breast cancer. And I know I've had these talks many times, but honestly, Dr. Anna, the number of times I still hear that hormones cause cancer, I would love for you to just briefly even touch on the Women's Health Initiative, because I think it's important that we don't miss that piece of the conversation for anyone who's listening.
Yeah, no, I mean, it's really important. So when the Women's Health Initiative 2002 was published, it showed that oral estrogens were causing increasing cardiovascular disease, and the combination Premarin Provera, which is synthetic, again, that's a synthetic progestin, caused an increased risk of breast cancer. And that is true to date, right? That information that was published in 2002, they followed it up in 2022 with the 20-year follow-up to the Women's Health Initiative study. And that was published showing that, yes, oral estrogens, Premarin, pregnant marriage urine, has over 30 different forms or metabolites of estrogen in it. Is this that's oral form of estrogen? Yes, it's associated with stroke and heart disease. No, it is not associated with breast cancer. So that is confirmed for the last 20 years, and other studies have confirmed the same thing. And but transdermal estrogen, it takes away the risk for blood clot and lipid abnormalities. So you bypass that risk factor with topical estrogens or transdermal estrogens or vaginal estrogen. And so you want to avoid oral estrogen for those reasons, definitely postmenopause, for the increased risk of stroke and heart disease. And it's nuanced too. There's certain clients that you may use it for a certain amount of time. But anyway, pretty much I go transdermal postmenopause. And then the progestin, avoid those. The progestins in birth control pills cause significant dysfunction. The progestins in hormone replacement therapy cause significant dysfunction, increase your risk for breast cancer. And this, again, is well established for the last over 2 decades. And so we look at the different forms of progestin. So Provera, medroxyprogesterone, even though it has the word progesterone in it, it's medroxyprogesterone. And that is a progestin, and it increases your risk for breast cancer significantly. So that arm, again, 20-year follow-up showed an increased risk of breast cancer on the progestins. Now, Fournier did an 88,000 person study in 2000, initial 55,000 person study in 2005. It was published. This is 20 years ago. 2005, it was published. And then a follow-up study with 88,000 women. And it's a French study, and that was published in 2008. And it looked at the types of progestins. Bioidentical oral micronized progesterone did not increase risk of breast cancer, but progestins did significantly 2 to 4 times an increased risk. So that's the area that we get into with breast cancer. Transdermally, we can feel that it's safe, and it's not going to increase your risk. Now, I treat women who have had breast cancer, and I say we're going to create bodies inhospitable to cancer. It's not the hormone itself that it's the way the hormone was used on the body that created, unless they were on a progestin, for instance, or had a long-term history of birth control pills. You want to understand the cause of the cancer to begin with, as much as we can figure that out. So, I take care of that patient to create bodies inhospitable to any cancer. And then uterine cancer. Now that's another specific thing. What happened, and this is fascinating because in the 1950s, Premarin was manufactured by Wyeth Ayers Pharmaceuticals, and I worked for Wyeth Ayers between college and medical school. I was in the drug metabolism department, so I have some inside knowledge here. I was mainly computerizing their drug metabolism department, but anyway, I was there. And Wyeth Ayers is the makers of PremPro and Premarin Provera, and and so when Premarin was released, and in the 1950s as the magic pill, right? Every woman, in over age 50 needs to be on this magic purple pill, right? And women started getting uterine cancer. And this was because they were, if they had their uterus and they were on estrogen unopposed by progesterone, they had an increased risk for uterine cancer. And that's where the progestins started. Like, okay, well, we can't patent bioidentical progesterone. Now, Prometrium is patented by its delivery mechanism because Prometrium is bioidentical progesterone. But it's in a peanut oil, and it's a delivery system was what was patented. And thank goodness they did, because we had good options that we could use for patients that wanted to use their prescription plans. But the other forms were progestins. And so when they said, okay, well, these progestins increase your risk of heart disease, et cetera. So if you don't have a uterus, you don't need them. And just do the estrogen without a uterus. But the problem is progesterone, as I started our conversation, is so important for neuroprotection. It's important for mood, anxiety, for memory, for cognition, for really brain function. And it's important for our bones. It's naturally, progesterone naturally can inhibit breast cancer or increase apoptosis, natural killer cells. So there's a benefit to using bioidentical natural progesterone. And it also opposes the estrogen on the uterus. So you want to maintain that healthy balance so that you don't get a uterine cancer. But that's where that whole thing, if you don't have a uterus, you don't need progesterone. You absolutely need progesterone. You don't need a progestin. That's the nuance.
Oh, well, thank you for explaining that. Now, speaking of progesterone, I have to ask you this because there's different types of progesterone as well. There's micronized, then there's compounded progesterone, and and then there's topical progesterone cream. I mean, that's how I started, was using the topical, and then I had to upgrade. It's like it just wasn't enough for me. I think I was about 48 when I started the topical progesterone. Now, what's the difference between micronized progesterone and compounded progesterone?
Well, I mean, a lot of compounded are using micronized progesterone. So
Okay.
micronized progesterone is the form where it's highly absorbable by your body. But the thing is, with any form of oral progesterone, 90% of that's metabolized out. And it's metabolized out into allopregnenolone derivatives, which is why that helps you, which produces more GABA, which is why that helps you sleep. So you have to look at, when we look at, say, for example, 100 milligrams oral progesterone is equivalent to a 10 milligram cream topically if you're absorbing it well. Yeah. So in my cream, I use micronized progesterone because it's better absorbed and better, more effective. So when I compound progesterone, they're always micronized. So definitely check with your pharmacy regarding that. But as far as I know, the compounders through PCCA are all using micronized progesterone in their
I'm gonna have to
compounds.
ask because I see a difference between the compounded and then the tablets that are micronized. I see a difference in my body, but
Yeah. So,
I'm
and it
extremely
may,
sensitive though.
yeah. And it can be also what it's combined with. So what it's filled, like what's filled in the capsule or the tablet or what it's pressed with, the binder. So that can be also a part of it too. But as far as I know, and be curious from our pharmacists listening, but as far as I know, the pharmacies that I've worked with are all using the micronized progesterone, USP micronized. That's the form. And
Yes.
that's the form I use in my balance cream, which is my USP micronized progesterone and pregnenolone. And in my Jolva, I use a micronized DHEA. We just get better absorption and better response from
Yeah.
the micronized forms. But not everyone does that. Yeah.
So let's get into sexual health because these are the things that it's almost like there's shame around it. Women are embarrassed about it. And I'll tell you a story. You might laugh about this, but I was at an event and I was in my 30s and there was, um, I don't know, some man who had too much to drink and he started talking to me about personal things that were really, really awkward for me. And he's like, yeah, well, with my wife, things just shut down. It's like a door that shut down. Like we can't have intimacy. And I was like, what? And this is like, I would have been about 38 years old at this time. I did not know that this can happen. And it's like an actual shutdown, like closing up shop. And then, obviously I've been in this space for a while of wellness, and I hear stories from many women who never took hormones, who perhaps maybe in some cases were not even sexually active, did not have a partner. And yeah, like there was no even having sex, even if you wanted to. Can you expand on that? And I know that you make Jelva, you make a cream for the vaginal area and it's DHEA. Maybe expand a little bit on that because so many people, I'm not going to say so many people, very few people talk about this aspect to
Yeah.
menopause.
Yeah, no, it's so true. And I'm a gynecologist. So early on, and I'm a gynecologic surgeon. So early on, treating women, especially early on in practice, with incontinence symptoms, prolapse symptoms, for whether it's anterior bladder prolapse or rectal prolapse or uterine prolapse, whether vaginal dryness, decreased ability to orgasm, recurrent urinary tract infections, recurrent vaginal infections. These all occur as we age more frequently. And to more of us, it's estimated that 85% of women over age 60 experience incontinence. And like that is not something you want to deal with. You don't want to deal with it now in your 30s, 40s, 50s. You don't want to deal with it when you're 70, 80. It is the straw that breaks the back of the caregiver and ends up having to put you in a nursing home. And I always joke, Sandy, I'm like, I have 4 daughters, strict boundaries on them as teenagers. I'm not giving them any excuse to tuck me away when I'm old. So,
Yeah.
I'm like, I'm going to keep my bladder healthy. But as a surgeon, I saw this happening, and I remember clients like couldn't even tolerate speculum exams, and stop having sex with their husband that they love, or they're powering through for the sake of their partner. And so that is the reality. And as we age, we will lose vaginal and bladder function and structure unless we do something about it. Pelvic floor exercises regularly and topical hormones regularly and good nutrition and gut health and detoxification and cell membrane health and mitochondria. I mean, that goes on and on and on. But as a surgeon early on in my practice in the 1990s, I recognized that one of the things that if I wanted to prevent a client, if I wanted to have a good surgical outcome, I wanted to get my client on hormones before surgery. I want vaginal surgery, and vaginal hormones. So for example, I mean, I would do sling procedures, but at the time, like this is early 2000s, doing bladder tacks, bladder slings, there was a lot of billboards on mesh erosions. And I don't know if you remember that. You drive by the highway and there'd be mesh erosion, some law firm coming after you for mesh erosion and all this stuff. And thinking, I don't ever want, I mean, that's just terrible. I never want a patient to suffer from something like that. But when the tissue gets thin, and then again, you operate on it and you don't replace any of the natural hormone or bacteria into the vagina again, you're going to get that erosion. It's just going to continue to get worse. And then what? Then you got to do another surgery and then another surgery. So I didn't want that with my patients. So I was studying hormones and I'm like, well, let's use, and I'd already been very familiar with the research on DHEA and testosterone, and of course vaginal estrogen, but specifically the strengthening factors in DHEA and testosterone to the pelvic floor muscle. So I started using DHEA vaginally and testosterone vaginally and topically on the vulva, as well as with suppositories internally. So a combination of different things. And I would start doing it pre-op, like I figured I'd need it at least 3 to 4 weeks before surgery to get a change. And, then I would 6 to 8 weeks before surgery to get a change. So I started really, playing with doses and the other ingredients that I was combining in with my compounded suppositories pre-op. And then, patients just started coming into their pre-op appointment. So they've been on my regimen for a couple months, and like always nutrition, diet, lifestyle is part of that. So it's never just one thing. But they'd come in for the pre-op appointment and say, Dr. Anna, I'm no longer having symptoms. I'm having the best orgasms. I went for a 5-mile run. I didn't need a panty liner. I wasn't leaking. I was with the kids on the trampoline. No problem. I'm like, okay, well, you don't need surgery. And so surgery was off the table. And that's a win. That's a huge win, not from the hospital's perspective when you're not bringing in surgeries, but as a person, as a woman, I'm like, yes, that's it. I'm all in for this. And then when I had retired my practice, the reason I created Julva is that my patients were like, Dr. Anna, no one will give us your cream, your creams and lotions. And, they're not familiar with how to even write that. And I said, I'm going to create something over the counter that's better than anything I could write on a prescription pad. And that's how I created Julva. The combination of the good took me a few years to really optimize the formula. And it does. It works better than anything to date that I can write on a prescription pad.
So then what you're saying is that it is reversible.
It is, well, in most cases, it is completely reversible if we catch it soon enough and we're patient and we do the other, we work on pelvic floor exercises as well. The combination is, I mean, for me, I didn't need to do surgeries for incontinence. I didn't need to do surgery. So, I mean, very rarely with 1 or 2. So to give you an idea, I used to do 2 to 3 surgeries per week on patients as a gynecologist, whether they were for hysterectomies, bladder surgeries, et cetera, 2 to 3 surgeries per week. As I got better and better in hormone prescribing and my method, my Keto Green method, and working with patients with that, with hormone balancing, I needed to do 2 to 3 major surgeries per year. That's the difference. So there were some that okay, well, uterine fibroids are too big, or you're coming in with a huge ovarian mass. I mean, I've got to operate. There's no question about it. But a lot of that preventable stuff, really your body has amazing capacity to heal. So that's the significance. That's the difference that I experienced personally, and why I'm a big proponent, because for myself, I want to keep everything that God gave me as long as I can. And so, but I respect clients who say, oh no, I just want it out. That's fine. But I really want you educated. And whether you've had a hysterectomy or not, and you've had your ovaries removed or you're gone through natural menopause, we want to optimize the hormones, especially that are affecting our function and quality of life as we age. So when you have pain every time you do something, why would you want to, right? So if sex hurts, you're not going to want to have sex. If you get a bladder infection or bacterial vaginosis every time after you have sex, why would you want to? And then that's where we shut down from the waist down. But you reverse that. I had a patient, for instance, she's 62 years old. I saw her last year. She came to see me in Dallas. So I put her on Julva, and we're doing mold detox with her. as well. And I could barely do a speculum exam. And she said, Dr. Anna, no one's been able to do a speculum exam on me in years. It's just really, really painful. And so I examined her, put her on Jolva. And this year she's, I've been following her, but this year I did like, you're due for your pap smear. She's like, I'm not worried this year. And I did her exam, no problem. It was 20 years younger. The
Wow.
vaginal area was 20 years younger, and she didn't have any pain, discomfort, and that's ideal. So you can reverse these changes. You can absolutely reverse these changes and improve quality of life for individuals.
And just to clarify for the listeners, the reason that this helps is because the vaginal tissue, it actually helps to thicken the tissue, so you're less prone to the pain from intercourse. You're less prone to infections and all of that because the tissue's restored from the DHEA. Does that make sense?
From the DHEA and the plant stem cells with the combination of the emollient ingredient. So there's plant stem cells from the alpine rose, which help to restore collagen and have a natural antiviral effect too. And the DHEA works where estrogen works on the mucosal layer. DHEA works all the way down to the muscle layer. So you get that rejuvenation of muscle. So example, you see a guy build, lifting weights at the gym, and he's been injecting testosterone. He goes from atrophic muscles to big bulky muscles. Like, okay, well, we're not injecting testosterone into the vagina. I'm not suggesting that, but DHA is a precursor at the cellular level to testosterone and estrogen. So you get that rejuvenation, and we see that shift. And also because healthy vaginal microbiome is predominantly lactobacillus. As we age, and it's also the vaginal pH is predominantly acidic. I mean, we want that acidic vaginal pH. It's a first line of defense into our womb, right? We don't want
Mhm.
infections up there, so you want to kill off bacteria, parasites, etc., from getting into our vagina, getting into our cervix and uterus, etc. So it's naturally acidic. As we age, it becomes more alkaline, and then the bacteria become more diverse, more bacterial vaginosis type species, more invaders. And that diversity is associated with disease and increased risk of cervical cancer. There's been a 20% increased risk in postmenopausal cervical cancer over the last 10 years. I think it's
Oh,
less. I think it's 5 years. I have to double check that number, but just reading it because I have a client who um, um, I saw recently who has a stage 4 cervical cancer diagnosis. She's 72 years old, was told by her doctor, was managed by their hormone specialist, et cetera. And, for decades, very proactive, exercises perfectly every, 3 to 5 times a week at the gym, nutrition to, best nutrition, following great, healthy, organic food, good, clean lifestyle, and sexually active all her postmenopausal years. But her physicians were treating her with hormones, never did a pelvic exam, never did a pap smear. She was told after age 55, she didn't need it anymore. And, and it's completely preventable. So when I came back into practice in Dallas last year, she came to see me, and she, had just been diagnosed with a stage 4 cervical cancer. So,
oh,
so it is painful to become aware of our, guidelines saying that, oh, you don't need to keep up with your pap smears. You absolutely do, first of all. And secondly, the rate's increasing. But why is the rate increasing? It's because of this, you know, imbalance of hormones within the vaginal tissue, as well as the guidelines saying that, oh, you don't need to get a pap smear, and also the hormone disruptors and toxins that our bodies had to deal with. So by creating a healthy environment for good, healthy bacteria, Lactobacillus crispatus predominantly, and keeping that tissue healthy, you completely reduce your risk of those diseases. But you got to get a pap smear regardless, because catching it
yes.
early is much better than oh, all of a sudden you're having bleeding. And this is what happened to her. She started having bleeding and they attributed it to her hormones. So they kept changing her doses for almost a year. And then she called me and I was like, go get a pap smear. Go, what did the ultrasound say? I mean, what did the pap smear say? And she's like, oh, they hadn't done it yet. They've just been adjusting my hormones. You guys, if someone's treating you that way, get a new doctor. Get a
Yeah.
new doctor.
Wow, that is so valuable. And one more question. I mean, I have a lot and I know we have to go, but DHEA is okay to use even around intercourse, right?
Oh, yeah. DHEA
Or
is fine for your male partner.
yes, because I know with a topical vaginal cream, obviously
Estrogen.
like estriol, you do not want like you do that after intercourse so
So, I
that
mean, that's just one more thing to worry about. So, I don't use vaginal estrogen very much at all with my patients, very rarely if there's an indication, but I use DHEA, you know,
yeah,
preferentially,
okay.
especially in heterosexual couples with a male partner. First of all, it will benefit them. It's not going to hurt them. They could use 10 times the amount and be, that would be their dose. But with estrogen, you don't want them to get extra estrogen. So, and
Right.
then you don't want to have to worry, oh, I need to wait, or I just had, I mean, it's just like another deterrent. We have enough to deter us at this
That's
point.
true. That's true. Okay, I know you have to go. Please tell us where we can find you. And I'm going to also have information in the show notes about Dr. Anna's product. But just let us know where is the best place for us to follow you.
Yeah, thank you. So definitely come to my website, which is dranna.com, DRANNA.com. And when you sign up for my email list, you will get a email inviting you to a live call with me, which is a live small group call. Usually we have 20 to 30 people on and I orient you, ask you, get to know you a little bit, address some common issues that come up. So it's a quick welcome call. And so I do those about once or twice a month. And so definitely want to come. That's the best way I can help you quickly. And it's completely free as part of my welcome sequence to my it's like my important, like my empire. I mean, it's really like I've got so many books and programs like to help orient you too. And then definitely on social media at the Girlfriend Doctor too.
Perfect. Thank you so much, Dr. Anna.
Thank you for having me, Sandy.
I hope you enjoyed this episode. Be sure to share it with someone you know might benefit. And always remember, when you rate, review, subscribe, you help to support my content and help me to keep going and bringing these conversations to you each and every week. Join me next week for a new topic, new guest, new exciting conversations to help you live your best life.